Hi everyone, my name is Karen Weintier. I'm a student here at the University of Wyoming and I am working on my master's degree in education. A little bit about me. I graduated from the College of Nursing at the University of New Mexico. Upon graduation, I accepted a nursing position in a Level 1 Trauma Surgical Burn Intensive Care Unit at the University of New Mexico Hospital. I moved to Gillette in 2011 and have been working in CCH's ICU since. I am nationally certified in critical care with a subspecialty of cardiac medicine, and I am also certified in progressive care nursing. This lecture is on endocrinology, and it is important for you to proceed through the entire lecture series. Activities will be based off this lecture for your class time. So let's get started. As far as endocrinology, it is important for you to know that an endocrine gland can profoundly affect other endocrine glands or other systems of the body. We'll start off with the pituitary disorders, and these usually result from too much or too little production or secretion of a hormone from this gland. So hyperpituitarism, also known as acromegaly, is the overproduction of growth hormone after the epiphysis of the long bones have sealed. This is in adulthood. However, it's often called gigantism in children before they've hit puberty and these epiphyses of long bones are still growing. Again, that is called gigantism. In the treatment of acromegaly, the transsphenoidal hypophysectomy is often the treatment of choice. And should they look for an alternative treatment, then they would go with radiation of 4 to 6 weeks in this patient group. So let's take a look at acromegaly, hyperpituitarism, and see how it's diagnosed, and we'll take a look at the clinical manifestations. First diagnosis, we're going to see a serum somatotropin, an increased level in growth hormone. The physician may order some x-rays and maybe an MRI, and you'll see a widening in the bone area there. Again, if patients that acquire hyperpituitarism after their long bones have sealed, you're going to see a widening in that bone, not in length. You're going to see a width in that bone. Patients will have a physical exam, and they will do an oral glucose challenge test. And this is basically an ingestion of oral glucose, and this should lower the growth hormone levels, but the growth hormone levels remain elevated in patients with acromegaly. Complications from hyperpituitary are increased intracranial pressure from an enlarged tumor, and the MRI will also identify a tumor too. And elevated blood sugars, which can result in diabetes. So, clinical manifestations for these patients would be an enlarged pituitary gland. Patient has headaches because of this pituitary gland taking up some space in the head. Some visual disturbances. These tumors, or the pituitary tumor, can lie close to the optic nerve and cause some of those visual disturbances. Slanting forehead, and we see that from the growth, the widening of the bones there. A protruding jaw. Patient might have an elevated blood pressure, and with elevated blood pressures, if they're not taken care of accurately, the heart is working too hard to get that blood pressure out of the body. Patients can develop congestive heart failure. Menstrual changes in females, and hypertrophy of soft tissue such as the tongue, skin, and visceral organs. Mention this before the sleep apnea because the enlarged tongue is probably most likely related to the sleep apnea. And again, the patient will have enlargement of the small bones in the hands and feet. So these patients will be saying that their feet are growing or their hands are getting big. As an adult, you shouldn't be changing shoe sizes every month. Nursing support is very important for this population. They have undergone some physical changes and need help in coping with that. Comfort. Their visceral organs have enlarged. They'll have headaches, so they need help and comfort with that. They'll also need post-operative care. And earlier I spoke of the hypophyseectomy, which is a surgical removal of the pituitary gland. The pituitary gland lies within the sella turica, a saddle-shaped depression sphenoid bone. The gland is removed by piercing the sphenoid with either a sublabial approach or more recently with a minimal invasive endoscopic endonasal approach. This reduces the surgical trauma, and this reduces recovery time for the patient. Medical treatment for acromegaly includes either oral administration of Parlodel, an oral anti-Parkinsonian drug which inhibits release of growth hormone in clients with acromegaly, or Dostinex, or a parenteral injection of octreotide, which is also known as sandostatin. So until the client has surgery or any type of radioactive treatment, nursing priorities will include helping the patient cope with the changes of their physical appearance, pacing activities to accommodate your patient's fatigue, relieving discomfort from headaches, abdominal distension resulting from an organ enlargement, and skeletal pain. So we definitely want to put some comfort levels for those patients and help them with those. Post-operatively for the patient with acromegaly, we're going to do frequent neurochecks. You might tip it this 15 minutes, every 15 minutes for the first hour, and then every 30 minutes for another hour, and then every hour for the next 18 hours or so, depending on what the physician orders. But we are looking at increased cranial pressure and nuchal rigidity. So that is where the patient, nuchal rigidity, we'll see where the patient you ask your patient to put their chin down to their chest, and they can't do it. Intracranial pressure is kind of hard if you don't have an intraventricular monitor, but you want to look for change in consciousness. If your patient comes in and you're talking to him, and they're doing real good, and then you come in 34 minutes later and they're lethargic or obtended, definitely start checking. Pupils, you always want to check that you got a lot on there, but I will tell you that pupils are kind of a late assessment finding on neurological changes for a patient. So you really want to see that mentation is first. Or, maybe your patient is very nice and now they're all of a sudden starting to jump out of bed and going crazy. So those are really primary indicators that something's not right with your patient. And then you have changes in your pupils and of your cranial nerves. Monitor nasal drainage. So we're going to look for a halo effect. And I put glucose on here because glucose is related to cerebrospinal fluid. However, I say this more as an intensive care nurse. If you have a halo effect, you're probably going to have blood in there. Well, blood has sugar. But if your patient has some clear drainage coming out of their nose, you don't know, well, maybe did they have a little bit of a nose issue, or, are they a little bit of an allergic reaction, they're dripping, or is this cerebrospinal fluid? That's definitely how you can tell the two, is you'll have sugar in there. So nasal discharge from the pulmonary area does not have sugar content in it. You want the patient to avoid using a straw, sneezing, coughing, bending over, or lifting anything to avoid dislodging the seal where the surgeon sealed that area there. So that is very, very important. Let's head on to diabetes insipidus. Diabetes insipidus is a disorder characterized by the excretion of extremely large volumes of urine output due to the inadequate amounts of H, also known as vasopressin, in the posterior pituitary. These patients can have urine output can be as high as 20 liters in 24 hours with a specific gravity of 1.002 or less. There are a couple of types of diabetes insipidus. Neurogenic or central diabetes insipidus develops when there is insufficient ADH from the posterior pituitary gland. A second type is called nephrogenic diabetes insipidus, and both have really the same symptoms. You're going to dump a lot of urine, and it's going to be very dilute and have a very low specific gravity. The difference is that the nephrogenic DI, the secretion of ADH, is normal, but the receptors in the renal tubules are partially or completely irresponsive to the hormone. These patients will have excessive thirst. Oral mucosa will be very, very dry, and their thirst will be constant. They'll just want to constantly drink something. They'll struggle with weakness, and of course dehydration, and weight loss can occur in this population. So, and a latter result if it's not taken care of, and this is not in your book, but more of a progressive care or critical care, or even if you're working in the emergency, hypovolemic shock due to the dehydration of these patients. So diagnostic findings, you can do a fluid deprivation test on these patients to diagnose diabetes insipidus and to differentiate between the nephrogenic and the neurogenic. So basically you're doing a fluid deprivation, withholding fluid for these patients for 5 to 6 hours. You're going to be measuring their urine, checking specific gravity and serum osmolality. At the completion of the fasting phase of the test, the client receives an infusion of desmopressin acetate, which is DDAVP. Remember, that's an important drug for you with these patients. It's a synthetic analog of vasopressin. If the urine becomes more concentrated following this infusion, the symptoms result from an insufficient ADH, also known as neurogenic. If the urine continues to dilute with lower specific gravity, the symptoms result from a failure of the renal tubules. So again, a fluid deprivation test is very important to identify. Again, I talked about the fluid deprivation test identifies whether it's the neurogenic or the nephrogenic. Now, the desmopressin acetate, which is the DDAVP, is a nasal solution, and lipressin diapid are synthetic ADH drugs used for the treatment in diabetes insipidus. Want to correct fluid volume deficits because they've peed everything out, and we want to check weights on these patients. So daily weights, if they're continuing to lose more fluid, they're going to lose weight, or pee, I should say. If they're continuously peeing, they're going to lose weight. We want to do strict input and outputs are indicated in these patients. We want to know everything that's going in and what's exact coming out. Is it positive or is it negative? Syndrome of inappropriate antidiuretic hormone, SIADH. Let's think about that for a minute. Inappropriate antidiuretic hormone, antidiuresis, anti-peeing. So too much ADH is excreted. This may be related to a lung tumor, CNS disorders, a brain tumor, cerebral vascular accident, a head trauma, drugs. Maybe the patient's taking too much vasopressin. That's ADH, a synthetic form. Maybe they don't know their regimen. Oral hypoglycemics can cause SIADH. Tricyclic antidepressants cause SIADH, and anesthetic drugs can cause SIADH. Assessment findings for these patients would be fluid retention. They're going to have headaches due to swelling in the brain, cerebral edema, because all that swelling, you got pressure in the head, no place for it to go. Muscle cramps, changes in cognition, loss of consciousness in these patients. They have nausea and vomiting. The diagnostics on this group of patients is low serum osmolarity and low sodium. So in their blood, the osmo is going to be very low, and they're going to have low sodium. Again, in the blood, in their chemistries, they're going to have low osmo and low sodium. Now, if we take a look at their urine, they're going to have high osmolarity and high sodium, because all that sodium is just going out. And so, important for these patients is daily weights. Again, I cannot emphasize how important for this group. SIADH patients get daily weights. Treatment for SIADH, one is osmotic diuretics. One of those is IV mannitol. It's important, you won't be using mannitol unless you're in the emergency room or you're in an intensive care unit. And just a little heads up with mannitol, if it has crystals in it, you definitely do not want to give this. So always check mannitol for crystallization. It sits for a while, and after a month or two of sitting, it can crystallize. So you never ever want to give mannitol when it has crystallized. Loop diuretics such as Lasix or furosemide. In a severe SIADH, we give 3% hypertonic IV solution. Again, this would be given in the ER or in the intensive care unit. Strict urine input and output is important. And we want to weigh this patient daily. Again, I cannot enforce how important this is. When we look or when we think in the clinical area that strict urine input and output is adequate, it's not. It is the daily weights that are really important.